Hello, everyone. I'm not JD Osborne. JD, who normally moderates our webinars, has the night off. I'm Troy Skubitz, the Senior Manager of Events and Education for CorneaGen. Thank you for participating in today's webinar entitled Grip and Rip ALK, an innovative approach presented by Dr. Mark Vital. Today, Dr. Vital shows you his pioneering grip and rip procedure that he uses in preparation of surgery. This must-see to believe technique called grip and rip will simplify the prepping of the recipient for transplant and provide you with a smooth interface for the donor tissue. This webinar will present insights into a new and unique method, which may deliver better overall results for your patients. Please know that Dr. Vital will take your questions at the end of his presentation. You can submit a question anytime during the webinar by using the questions box in the upper right-hand corner of your screen. Click on the plus sign. It will open a text box for you to write and send your comments or questions. We'll do our best to answer as many of them as possible during our allotted time. Now, let me tell you a little bit about our presenter, Dr. Mark Vital. Dr. Vital is a board-certified ophthalmologist with Houston Eye Associates. He received his medical degree from the University of Texas Southwestern Medical School in Dallas and completed his fellowship in cornea and external disease under Dr. Lanier at Houston Eye Associates. Dr. Vital is a member of the American Academy of Ophthalmology, the Texas Ophthalmological Association, and the Texas Medical Association. His specialties are anterior segment, cataract, cornea and external disease, and he is experienced in treating complex ocular issues such as infections, trauma, corneal dystrophies, corneal scars, pterygia, what do we have here? Cataracts and other anterior segment problems. It is my great pleasure to have you with us tonight, Dr. Vital. Welcome.
Thank you very much, Troy. Appreciate it.
Well, I hope I didn't misrepresent anything. I hope everything I said was accurate.
Not at all. Not at all. Okay. And just poke JD in the ribs, your hair looks much better than his.
Thank you. I'll take that. Yes. If you said the other way around, I better get new mirrors in my house.
Well, hello, everybody. I thank you all for tuning in. You know, we're doing these kinds of things differently now in the land of COVID or in the era of COVID. And, you know, in some ways it presents challenges, but in other ways presents opportunities. We're able to reach out and talk to many more of you than we may otherwise have been because of everybody's familiarity now with doing these things in a webinar type fashion. So I'm really honored and privileged to be able to share this technique with everyone. And I hope that you can get some value from this.
And we're gonna get to your presentation, but before we get started, we want to best understand our audience's experience levels. So we've developed a few poll questions to learn a little bit about you. And during each poll question, you'll be able to click on the answer that best reflects your experiences. So, Dr. Vital, shall we look at the first poll question?
Sounds great. Let's go.
Let's see what it is here. I see here, how are you currently performing lamellar keratoplasty, ALK or DALK? So click on the answer that best suits you. Is it manual dissection, visco dissection, big bubble, or other? We're going to give you about 15 more seconds to respond to our question. And then we'll ask Emily to show us the results. Go ahead, Emily. There we go. Dr. Vital, what do you think of that?
A lot of people doing big bubble, which is very interesting, and I think you will find some benefit to what we have to talk about tonight.
That's great. Good. How about our second poll question? Let's see. What is your frequency of ALK per year? So is it less than 10? Is it somewhere between 10 and 20? Is it more than 20? Or is it 0? Which is it for you? Let's give you about 15 seconds to respond. All right, and let's check out the answer. Less than 10.
So quite a few people that are dipping their toes into doing deep anterior lamellar keratoplasty but most people are not doing a high volume. So again, something that I think feeds right into the things that we have to talk about tonight.
That's good. We have a third poll question, and it is stated as such. What do you feel your conversion rate to PKP is? Is it less than 1%, between 1 and 5%, between 5 and 10%, or more than 10%? If you'll click on the answer that best represents your experiences, we'd appreciate that. We'll give you about 10 more seconds. And let's take a look.
So kind of a two-pronged kind of or bimodal kind of distribution here, where we have some with high frequency of conversion to PKP and some with much less. So again, consistent with what we know.
Very good. And then finally, our last poll question asks, what do you feel your perforation rate is for ALK? Is it less than 1%, between 1 and 5%, between 5 and 10%, or more than 10%? So click on the answer that best represents your experiences, and then we'll take a look in about 5 seconds. And Emily, show us the results.
Yes, so relatively high perforation rate, I would say, with anywhere between 5 and 10 or more than 10% for the majority of people.
That's great. Well, so Dr. Vital, I'm going to disappear while you go through your presentation, and go ahead and take it away. I'll see you at the end of the show.
So why lamellar instead of PKP? So this is something that I think we already all know. We know that lamellar keratoplasty will provide for a stronger wound, maintain the endothelial cells with less rejection problems. We don't have the large open wound that can potentially lead to other issues of suprachoroidal hemorrhage and other complications like cataract and so forth. Less likelihood of postoperative ankle closure issues, and less potential for astigmatism. So Emily, can I go to, let's see, next slide from here? Thank you, Emily. If you can advance for me, that would be great, since I can't quite reach. I appreciate that. So which technique is best? If we're set out from the onset that we're going to do an anterior lamellar keratoplasty, we have some choices. Which ones do we want to do? And there's manual dissection for DALK, which is frequently done in a debulking procedure anyway before big bubble, at least the way a lot of people are doing it. There's visco bubbles, and then there's the traditional air big bubble DALK that we think of. And then we have advantages and disadvantages that are listed here, again, that most of us already know. Manual dissection being very quick, big bubble also being fairly fast. We know that it particularly has the advantages of a clear interface, which is really what we're going after. Why we're trying to achieve that big bubble in the first place is really all about trying to clear out any opacity that might be in the stroma, and to allow the interface that we get between the new tissue and the recipient tissue to be very, very clear. Disadvantages of these, with any of these procedures, of course, there's the risk of perforation. So we want to be careful of that. There can be issues with retained viscoelastic, and there can be issues with time in some of these procedures in terms of how difficult they are. Next slide. So this is a study done from the clinical ophthalmology in 2011, and basically is looking at what are the common complications of deep anterior lamellar keratoplasty in the early learning phase. This was a study out of Egypt with 2 surgeons doing 40 cases between the 2 of them. And when we look here, we can see overall perforation rate of about 22.5%. Over their first 40 cases. And on the right, this pie chart illustrates all of the different places or problems where they perforated. Either removal of the bubble roof, trephination, bubble puncture, stromal debulking, or needle insertion. All of those are sharp areas involved in the process of performing a big bubble that can lead to problems and then possibly lead to perforation, maybe or maybe not conversion to PKP, depending on the size or location of that perforation. Really, if we can avoid that, we would have the holy grail of procedures. We'd really want to try to see if we can get around that. Some surgeons have been able to master that and others have not. Again, this particular study is showing what's the early learning curve. On the next slide, this next study will talk about what's going on for experienced surgeons. So with the Dr. Anwar's big bubble coming out of India, there are a lot of Indian physicians who are using this technique and have gotten a lot of exposure to it. So this particular study was done out of the Indian Journal of Ophthalmology just this summer in June of 2021. And it took surgeons that had done at least 10 DALK procedures and typically do in the range of 20 or more PKPs in a given year, and looked at what were their preferred techniques. So we see manual DALK by about a third, big bubble by a third, and visco-assisted DALK by about a third, and looked at what were their complication rates and learning curves and issues with that. In the chart on the right here, we can see that this is a little bit busy, but in that chart, we can see that approximately 50% of those surgeons were able to achieve big bubble success in greater than 50% of their cases. So half of surgeons are having problems where such that more than or in the range of half of their cases that they're doing with the big bubble are not working properly. When you look at big bubble success rate in the range of 75% of those cases by those experienced surgeons being successful, the number of those surgeons in cases that are successful drop to the range of about 20%. So across the board, over 50% of the surgeons at some point are having problems. And oftentimes, even in the hands of experienced surgeons, we're still seeing high rates of perforation and conversion to PKP. Next slide. So which technique is best? Again, there are advantages and disadvantages of all these techniques. I would like to propose tonight that the grip and rip ALK, that the way we've coined it, is one of the better and more safe and reliable and reproducible ways of doing anterior lamellar keratoplasty. First of all, the name, where did that come from? Well, I was at the Aspen Cornea Conference and we were all sharing random cases and we were all showing various videos. This was a couple years back. And I pulled out a video of one of my ALK procedures and it got a lot of attention. Later on during the conference, one of the vendors there, I think he was from Moria, said, "Hey, you're that grip and rip guy, right?" And we really didn't have a name for it. I just called it ALK because I just was kind of under the assumption that a lot of people did it the same way I did it. And the grip and rip name kind of stuck, right? It's kitschy. Well, advantages. What's going on when we're doing an ALK is we learn that really the interface is what's most important. And if we can get an interface that doesn't require sharp dissection, and at the same time gives us an interface that's smooth without the interface haze, again, we're achieving what we're really after. So grip and rip ALK, taught to me by my partner, John Goosey, what is something that I think it really hits on these advantages. It's fast, it's easy to learn and perform, it's extremely low risk of perforation. I've had, I would estimate, 3 perforations over the since approximately 2005 when I started doing this. I asked CorneaGen to pull my data and I had about 230 cases since 2010. And in that period of time, I can think of specifically 2 cases that perforated, one because of peripheral perforation with the trephination, and one because the patient had previously already had hydrops. And in the pull technique, I don't recommend doing that because at that point, the decimase is already weak and you may get another perforation of the decimase. I have done it in cases of hydrops where we're really trying to avoid going to PKP and had it work successfully, but I would definitely put a word of caution in that situation. Again, disadvantages. What are the disadvantages? Of course, there's the risk of interface haze. The better you get at doing the pull, I think the less haze and less problems that you get into, but that comes much, much easier than trying to perform a big bubble. Dr. Goosey taught me you get no extra points for level of difficulty. Corneal surgery is not like diving. So we want to try to keep it simple. If we can keep it simple, more of us can get it done, more of us can get it done successfully, and we end up with more happy patients with grafts that last many more years than if they had a PKP. So why doesn't everyone do the grip and rip? Well, we've seen that stromal haze caused by sharp dissection, and that makes us more wary and more apt to say, hey, I want a really clear cornea. I'd rather go straight to PKP. And in all honesty, people are really intimidated once they see this procedure. So I really like to take that down and tell you that it's not nearly as difficult or as scary as it may look when you see it, and hopefully get you over the hump to say, hey, this is something that I want to try. Next slide. So let's take this step by step in a real scenario. Previously, when I presented about grip and rip ALK about 3 years ago with CorneaGen, I showed several cases, about 5 cases, one after the other, to show that this is a reproducible procedure. And if you go to the CorneaGen website, you'll be able to go there and you can review that presentation, which also has some information that we may not go into a lot of depth with here. But here I really wanted to take a case from start to finish. So what we're going to talk about are what are the best situations for grip and rip ALK. In other words, things that have anterior opacities, thinnings, or ectatic procedures, shape problems, those which we know, which are keratoconus, stromal scars, Bowman's compromise, things like that. Avoid previous decimase rupture like hydrops, and think carefully on deep posterior stromal scars, because if the scar is particularly deep, we may not get it all. Even debulking procedures that remove most of the scar, even if we leave some posterior scarring, patients can still get dramatic benefit without the risks of PKP. We'll talk about what you need in terms of instruments, and do you need a backup cornea? The simple answer to that one is no. How do we do it? We'll go through the steps, what happens post-op, and all the care that's involved there, and then what are the long-term results in terms of clarity, shape, and vision. Next slide. So as a walkthrough case, this is a 33-year-old female with keratoconus, uncorrected vision in the right eye 2200 and uncorrected vision in the left eye of count fingers. Her refraction is here as you see it, with high astigmatism and with glasses still limitation in the left eye to 2400. On history, the patient was having difficulty with her contact lenses, and despite being able to get good fit with scleral lenses, was still having problems because of intrastromal scarring, apical scarring with her keratoconus, and even with her scleral contact lenses was not achieving good vision. So we'll go through pre-op diagnosis, pre-op diagnostics, and decision for surgery. Next slide. So here I've kind of amalgamated several of the different diagnostic tests so that you can see them together. On the left-hand side here, you can see the pentacam for the right eye, along with the Schlimmflug images down below. And on the left side, on the right side of the screen, the left eye. We can see here in the Bellin ambrosia display, the significant ectasia that's present for both eyes, left eye being dramatically worse, and with Ks in the range of about early 70. So this is in the range of kind of the early cases where I'll start to consider lamellar keratoplasty, usually in the ranges of cases in 65 and above, not to exclude cases as high as 100, 110 diopters in Kmax. On the right side, this patient would probably be towards the upper limits of where we could be thinking about cross-linking. And cross-linking, of course, another discussion for another time, but although on the high side, maybe not completely out of the question for the right eye. Next slide. For those of you who like to see the ABCD staging, I went ahead and included it here. You can see advanced keratoconus really for both sides, in particular on the left with very steep cones, both anterior, posterior curves being steep, and a very thin pachymetry of 302 microns on the left side. The next slide. Here's the OCT, just to confirm. Again, with this particular raster on the left eye, we see a pachymetry of 436, but the pentacam picks up the thinnest location, which is really about 300 microns. You can see the dramatic change in shape and the coning on the left side, change in shape rather, and the coning on the left side as compared to the right. Next slide. So when we've made the decision to do surgery, and this patient decided that she'd like to go ahead and proceed with an anterior lamellar keratoplasty to try to get rid of that apical scar and to try to flatten the cornea to get better and easier correction with a scleral contact lens. We go to CorneaGen's website and put in for ordering for the cornea, which I think they've got a great platform for that. And on Cornea Day, we end up with present. This is kind of what it looks like. Particularly for those of you who may not be familiar with how the tissue is received from CorneaGen, they do a great job in packaging, and I wanted to go through that as well. Next slide. Here's the donor tissue. The age on this particular donor is 65 with a death to preservation time of 24 hours. These corneas are corneas that can be saved when they're right at the edge of being timed out. Endothelial cell density in this particular case is 3,000. I will oftentimes ask for a good cell count on a cornea like this if I can, in the rare instance that there's a possibility of a perforation. And this is what I would do for those people who are trying first off, is go ahead and ask for a cornea that's of PKP quality. If necessary, you can go ahead and actually sew this on as a PKP rather than just doing it as an ALK. But again, for those cases that are near timing out and those cases that have poor endothelial cell counts, they're great tissues for ALK. I like to ask for amphotericin B added to the solution to avoid any problems with fungal keratitis. I've been lucky enough in my career to only ever have one, but one is all you want, or more than all you want, really. And anything we can do to avoid that, I like to go ahead and take that opportunity. The graft thickness in this case is 407 microns and the graft diameter is 9, which is pretty typical. I usually basically tell them, prepare this anterior stroma as if you were doing a DSEC, and that residual 100 microns of tissue roughly is what's left behind, and we get about a 400 micron cap on top of that. Next slide. Here's the packaging, comes in the cooler, well labeled, a little sticker to differentiate your ALKs from your DSECs and your DMECs and your PKPs, whole corneas. Next slide. Here you can see the packaging outside with the paperwork, which easily allows you to confirm the paperwork against the cornea without having to open the packaging, which is great. And next slide. Here's the basic kit for what you need in doing grip and rip and ALK. There's really not a lot to it. So on the left slide here, you can see the Wexels and the drape scissors and the speculum, of course, basic stuff. The BSS bottle. We usually use a 30 gauge, a 30 degree or 15 degree blade. Now, oftentimes I'm using actually an MVR blade, so I have both sides of it. We use that in cutting sutures. That next blade next to it is a pink blade, which is a round blade we call a feather blade. There are various different types and manufacturers who do blades that are similar to that, and it's not out of the question to just use a crescent blade as well. You've got your calipers, a tying forceps. Next to the right of the tying forceps is a green forceps, basically a green muscle forceps, so that you can get a really good grip on the cornea. You'll see why we need that as we go forward. Next to that, a Bishop forceps. Below that, we have a Westcott scissors, 2.12 forceps, and 2 curved locking needle holders, which I use from stores. The suture that I like to use is the CU1 needle on a 12-inch suture from ALK, which I think does really good for throws. Everybody will have their favorite, and there's no particular reason you have to use that particular needle. Next slide. Normally, when I do ALKs, I am choosing an 8.5 and a 9 millimeter in terms of the donor and the recipient and donor tissues, and we oversize those by 0.5. In some cases, we may go a little bit larger or a little bit smaller, but most of the time, I'm choosing an 8.5 and a 9. I like to use the Barron radial vacuum tree fines because of the way they make marks on the cornea, which you'll get to see. They do a really great job. Again, everybody has their preferences in terms of tree fines. There's no particular reason that you have to use one tree fine over another. Next slide. In the scope, I like to remind people when they're doing transplants, particularly if you're not doing tons of them, to remember to keep that scope perpendicular and squared up to avoid any parallax, particularly as we're doing cones. As these cases, these cones are very, very steep, it's easy to get lots of parallax and then end up with a graft that's not centered well on your cornea. So keeping the scope square is good, and you can do that by various scopes have lines in them that will help you to do that if they don't center on their own. Next slide. Surgical steps, you want to make sure that we're gonna go through and do each one of these steps one after the other. We're gonna mark for centration, we're gonna size the graft, we're gonna select our tree fines, prepare the donor, determine our depth of trephination and our donor marking. We're gonna score the stroma, we're gonna do the grip and rip. In the bed, there's really no need to touch it, wipe it, irrigate it, or anything. We're just gonna take off the old, put on the new. In the case where there's some bleeding, it's okay to irrigate the interface or sweep the interface if necessary. Place the donor on, suture. I rotate knots to the periphery. I don't bury my knots. The reason I don't bury my knots is it makes removing sutures much easier. If you're tying a really good square surgeon's knot, it's really not necessary to bury the knots. We just rotate them to the periphery. Patients do really fine once the epithelium covers those knots. We place a bandage contact lens so that they're more comfortable until that epithelium does cover the new donor cornea. And total time for all of this is usually between 45 and 60 minutes, depending on the music. On the right there, you can see some of my bad choices when the music was really, really good. Next slide. So this is an OCT of that 33-year-old patient that we discussed. And as you can see the OCT run here, you can see the scarring in the anterior stroma, and you can see the thinning of the cornea at the apex. Next slide. In this slide here, you'll see me using the caliper to choose my 8.5. Then I mark the center. I just do that visually. I don't usually try to measure to find the center. I used to do that, but I find that just eyeing it really gets you very close to the center. We're very good at picking out the center of circles. So I usually do that at least to start. Next slide. After that, I'll take my 8.5 millimeter calipers and measure out where the edges of my graft are going to be so that I have a rough idea of where I'm going to land. In the cases where we may be doing, say, a herpetic scar where there's vascularization, or some other type of scar where we may impact other opacities or problems in the peripheral cornea, it's good to know where you're going to end up. And then once we do that, I use a gentian violet pen to mark my center so that when I'm placing the trephine, it's easier to see. And I'm kind of committed to that center point. After that, we pull out the barren trephine. This is the recipient trephine. Verified has a little print of 8.5 on there. We look at the barrel. There's an inner blade and an outer barrel. We're going to advance that barrel, that inner blade, to match up with the inner barrel. You can see that there. Then we back up 3/4 turns, check to make sure we went in the right direction. And now we're ready to place that trephine on. So close one eye, looking through one ocular of the operating microscope, center the crosshairs on our center mark and apply suction and let that sit. We want that to sit for a good minute at least. I just let it go ahead and sit while I'm completely preparing the donor. And next slide. Here we've got preparation of the donor, and I'm basically just marking that recipient, that donor trephine. The 4 holes here for suction, and then the center hole in the middle. Those will transfer onto our donor cornea, and those will match up perfectly with the recipient trephine and the marks that the recipient trephine will make, so that there's no guessing and matching those two things up. Here we're taking off the donor from the carrier after we've rinsed it off, and you can see just how clear it is. Again, mark the center visually. Then we're going to take that graft, we'll flip it over. We've got stroma there, remember no endothelium because this is a lamellar. And then we're going to place that center dot in the well over our recipient, our donor trephine spot. Now, we don't have to commit to our center dot there. If our center dot is off a little bit, sometimes I have good days, sometimes I have bad days. What we really want to know, what we really want to concentrate on is where those 4 holes are relative to the edges of our graft. We want to try to keep those even, and that's really going to dictate what our center is. I reconfirm that I've got a 9. Although our donor said that it was exactly a 9, we can see that that sticks out from the edges, and I usually verify that those edges are all the way around and then punch out the 9. If I'm doing a very, very steep cornea, then I might actually not even punch the cornea out and take it as is, just laying it on top. After we've applied suction, our marks will transfer over to the donor, and then we'll remove that suction tubing so it doesn't get snagged on something and then pulled off the Mayo stand accidentally. Put the cover on, no need for BSS on top of that because we don't want to induce any swelling in our donor. We go back, we do 3/4 turns back to our flush point, which brings us to 0. Then we can do our cut, which is another 3 to 4/4 turns, each quarter turn being about 63 microns. And then when we remove that, we've got indentations from the marks that are naturally on the trephine, and I mark every other mark so that that keeps us straight. And those marks are the ones that are going to line us up with our donor. Next slide. I intentionally don't go all the way through with the trephine, even when I'm doing PKPs. Naturally, we don't want to do that in a lamellar, but even with PKPs, I always stop at this point. This allows you at this point to assess what you've got, whether or not you're going to be able to continue with surgery, if you need to make some change in plans. Gives you time to be calm and collect yourself before you move on to the next steps. This particular OCT is showing the depth of that cut that we've made. And by doing 4 quarter turns, we're at 250 microns in depth in terms of our peripheral cut. Next slide. Here, we're going to take 0.12 and our feather blade, and we're going to score. So we're just trying to make a nick. I used to dissect into the peripheral cornea about 1 millimeter or 2. It's really not necessary. All we're trying to do, in the same way that you would score a glass tile if you're trying to break it, we're just trying to weaken those peripheral fibers, because those peripheral fibers of the cornea, we know, both peripheral and superficial, are stronger and more adherent. The central and deeper fibers are less adherent. So here we're pulling a little bit just to make a little score. We then take the jaws of life. Can you pause right here for me, Emily? So Emily will go back for me. As we go, and you can just let that run again, Emily. As we go ahead and place the green forceps, the jaws of the green forceps can look very, very ominous. So you don't want to be afraid of these jaws. They're really not going to do any harm to the cornea. We're just trying to take a really good posterior bite of the tissue that we're trying to remove so that we have a good hold on it. And I used to do this with 0.12 forceps, and because of the amount of pull that you're doing on the with those 0.12s, you'll actually start to damage your 0.12 forceps, and you'll go through them really fast. So that's where we started to use the green forceps, because it's just a heavier forceps that allows you to get a really good grip. So we use the 0.12 just to make sure that I can get a good grip with the green forceps. We then basically reflect that back. We use the bishop forceps again to have another heavy forceps on our rim. And we're going to pull in the plane of the iris. We're not pulling up towards the microscope. We're pulling down towards the patient's feet. And as we do that, you'll gradually see the cornea will release, and we'll get a smooth pull all the way down to the 6 o'clock position. Then I take the feather blade again, and from the periphery back to the center, complete that cut from the back side. There's lots of ways you can do that. Of course, you can do that with scissors or however you feel comfortable. It's just an easy way to do it. Now, again, as I zoom in here and get a little focus, you'll be able to see that there is definitely stromal fibers left. The cornea is thinner in the center than it is in the periphery, but nice and smooth. Very, very smooth interface, much smoother than you can get with a blade, and much safer than you can do with a blade by just tearing it and blunt dissection. Now, can you do this over and over? Yes, I did 3 of these last week. You can do this over and over and over and over and over again, and your risk of perforation is very, 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 very low, because the Decimase is strong and the cornea naturally wants to separate along its posterior lamella. Next slide. So here is that bed. And again, no reason to rush in this situation, right? We can take our time. Cornea is nice and stable, patient's comfortable. We just use block anesthesia. You can see how thin it gets. In some cases, the apex of the cone can go all the way down to Decimase, but the depth, again, is not as important as the smoothness of the interface. This is really what allows us to get a nice, clear cornea once everything's all said and done and healed. Next slide. This is just giving you a closer look of what's been removed from the cornea. And then we'll take our new donor and place that and just rest it on place. And you can orient that, excuse me, you can orient that the way you need to. If there's some peripheral arcus, or a little bit of opacity in the donor, you can put that underneath the lid. I'll usually put that superiorly at 12 o'clock. In this case, in most cases, the cornea is very clear, particularly with this size of a graft, and we just orient it in place. In this particular example, I've intentionally left this graft a little bit, off center and crooked and everything like that, so we can look at the OCT. And next slide. On the OCT, just with the cornea resting in place, no sutures, we can see the recipient bed and the apposition of that bed to the donor. We can see the sharp edge of our donor from our punch in the superior illustration on the OCT. We can see the space there. So we can get a relative sense of how thick that recipient cornea is, the recipient residual bed is, because we know that that donor cornea is 404 microns. So we're dealing with tissue here on the back that's in the range of about 100 to 150 microns. Sometimes it's a little thinner. This is probably on the thicker range of where I would normally see my grafts ending up. But I'm not overly concerned about getting super, super deep or achieving any particular depth, because even if I'm a little thick and I end up at 200 microns, or I'm a little thin and I end up at 50 microns, those variations in depth really have no significant bearing on the visual acuity afterwards. Next slide. Next step is, of course, putting in sutures. I'm not going to torture you guys through all the suture placement, but I do want to point out how sutures should be placed in this. We really want that donor tissue to dive into the wound edge. And so we're going to place the first suture through that dot that's made by our donor trephine, usually either in the center or towards the more central portion of the mark there. And we want to come out on the edge. We don't want to do a full through and through bite, because it doesn't tend to drive the donor tissue posterior into the bed. And you can have problems with the epithelium not wanting to grow over the donor. It wants to grow down into the interface, and we, of course, don't want that. So we're going to make sure that our suture exits the donor at the edge in the periphery. Then we're going to take a deep bite, shallow bite on the donor, a deep bite on the recipient, and come out just posterior to our mark. So here I've got my first 2 in. You'll see stretch as we're flattening the cone. Now I've got 3 in. I'm placing the 4th here. And as you place the 4th, and tighten that suture up, you should see those stria in the center flatten out. Now, when I suture my corneas, I always suture dry, not wet, because I want to be able to see those stria in the anterior cornea. And seeing those stria in the anterior cornea helps control your astigmatism. So we go from a line when we have 2, to a triangle when we have 3, and then to a square when we have 4. Next slide. Here I've got in 7, we're placing the 8th. So we go from a nice square to an octagon. Again, you can see that stria. And as we pull in that last suture, we lock it in place. I always do 3-1-1 knots. Again, everyone has their preferences on how they'd like to do their suturing. I don't think that that is absolutely integral, and you can customize this to whatever your favorite suturing technique or whatever you feel is most appropriate for the case as you see fit. Next slide. Here's putting in the last suture. After I place sutures, I break them rather than cutting. Much, much faster. A little trick that not everyone does, but we tie the knot, we then rotate the knot, pull the knot to the edge, and then I snap the suture off, which keeps you moving very quickly. And then we alternate forehands, backhands. Here, as I zoom in, you'll see some wrinkles on the superior part, or really inferior part of the cornea, superior part of your view here. You'll see some wrinkles in the peripheral cornea. That's happening because we've now shortened the arc length on the posterior stroma, and that posterior stroma will wrinkle. It can be concerning at first, but ultimately those wrinkles will iron themselves out as edema and things resolve and as the donor heals to the recipient. Next slide. Here's the OCT immediately after. You can see those wrinkles in the posterior stroma, and you can see the apposition of the donor cornea to the recipient bed. Next slide. Next, we cut the sutures. Again, here I usually use an MDR blade. A 15-degree or 30-degree also works well. And I cut right on the knots, and we keep those knots rotated out to the periphery. Next, I just use a tying forceps to tuck in our donor tissue underneath the recipient rim, again with the intent of encouraging those stem cells along the edge to grow over the top of our donor rather than trying to grow under the donor, and then place a contact lens. The contact lens helps the patient with comfort, particularly with those knots being up, and makes them feel very comfortable and encourages epithelial healing of the surface. So this basically concludes the surgery where we'd be here. I don't normally put in subconj injections of antibiotics or steroids. We just use our regular postoperative drops, and patient goes off to the recovery room with patch and shield. Next slide. So here's our final OCT with the bandage contact lens in place. Again, to show the apposition between the donor and the recipient and the relative thickness of the contact lens in respect to the donor cornea, which we know is 400 microns, and the recipient cornea, the recipient bed, I should say, which we know is, in this case, around 150 to 160 microns. So here, Emily, you can show me the next slide. I believe that's the last for the, yeah. So I'd like to pause right here for a moment. If there are any questions, Troy, that anybody has would like to ask, since we've just gone through the procedure, I'd like to open it up for that if there's anybody that has any questions specifically on that.
We do have a few questions here, so we can address them. One says here, can you spell the name of the gripper? Was it Green, spelled G-R-E-E-N, Green?
Correct, Green, G-R-E-E-N, yes.
Great. Let's see here. Can you do this technique for every thin corneas like 200 microns? Can you do this technique for very thin corneas like 200 microns?
It seems counterintuitive, but the thinner the cornea, the easier the rip. And that's because there's less stromal tissue holding on and less of those unorganized tissue and more of the organized tissue posteriorly. I've done this procedure. I think the thinnest cornea I've done with this grip and rip technique was 150 microns. So when we started, and we tore at that point, and in the tear did not buttonhole that cornea. Even at that 150 micron level, we were still able to get a stromal dissection at that level.
Very good. And this is related to that as well. It says, how do you determine the thickness of donor tissue?
So I do roughly about 400 microns on everybody. I asked CorneaGen to provide me a anterior donor cap that would be what they would throw out if they were doing a desec, or they were cutting for a desec, that cap that you throw away. And at one point we have advocated, and other people have since advocated the same thing, that if you're doing a desec, potentially you could split this cornea into two. Use the anterior cap for a lamellar, for a cone patient, and on the same day, use the posterior stroma for a desec.
Very good. Here's another question here. It says, can you trephine to a greater depth before ripping to leave less host stroma behind?
You can, but at least in my experience, I don't feel like the depth of the trephination corresponds directly to the depth of your dissection when you're pulling. So just because I do 3/4 turns, which is about 190 microns, versus 4/4 turns, which would be more like 250 microns, I don't feel like I can reliably control the depth of that interface. And again, my big contention is it doesn't really matter. You don't have to be at any particular depth in order for all this to work. You just need to remove the anterior portion of the cornea such that you can have the new donor cornea have a bed to sit in. The thickest cornea that I've ever seen, the thickest natural cornea that I've ever seen for a patient, this was a patient in her 20s with no corneal disease, as far as I'm aware, who has a history in her family of other family members with thick corneas, was 850 microns. She was 20/20 uncorrected with an 850 micron cornea in both eyes. So I would strongly contend that the thickness of the cornea doesn't matter. We want to make sure that it is not edematous and thick, but as long as it's compact and thick, the patient should see through it just fine.
Very good. You have a shout out here. Somebody says, great technique. That's nice. So let's see here. Would you ever consider a femto?
Femto is not out of the question. I'm not much of a laser guy. No, in a lot of these ALKs, we're doing the ALK for the fact that the cornea is not clear. So the clarity problem immediately can potentially cause a problem for your ability to do at least the lamellar portion of the cut. Now the trephination, if you want to use the femto to do your trephination, no problem. I see no problem with that if that's your preference.
Very good. We have more questions. Should we keep going, or do you want to finish your presentation and then answer the rest?
Yeah, let's keep going. Let's get those while they're hot.
Okay. Somebody wrote here, if you leave the knots out, when do you take the contact lens out?
So I leave the contact lens in usually for 1 week. At 1 week, the epithelium is completely healed in, I would say, 90% of cases. And we take the contact out at 1 week. And usually at that point, the patients are fine, knots are covered, and patient's ready to go. Patient will feel them a little bit for the next couple of days, maybe another day or two. And then after that, they're adjusted and they do fine without anything after that.
Okay. Have you, let's see here, have you seen cases where the stria do not resolve with time? I've been doing this for about 3 to 4 years now, and I have my second case where the stria do not resolve.
Depending on how dense those stria are, and sometimes, at least Dr. Goosey proposes that the age of the patient can matter in these cases. So particularly if you have a cone patient, a keratoconus patient, where you're doing lots of flattening and they're also over 40, you may not see those stria resolve as easily. Now you can take a cannula, once you have the graft completely sewn on, like you see in the picture that's up now, you can take a cannula and go into the interface and sweep those posterior wrinkles to orient them in different places. I have not been able to make them go away completely, but you can move them around so that at least they're not in the visual axis.
Very good. Somebody asked here, any special tips or tricks for doing grip and rip in cases post hydrops, where there is concern for previous break in Descemet's?
So with previous breaks in Descemet's, that's a situation where I would avoid this technique. You can see how much pulling we're doing. Descemet's is already ruptured once. There's a good chance it's going to rupture again. Now, not in all cases. I have done it successfully in hydrops, but again, you know that you've got posterior scarring that goes all the way through Descemet's. In those cases, you're probably going to be better off with a PKP.
Here's a question here. Has anyone tried using low concentration MMC on the bed to reduce stromal haze prior to the placement of donor cap?
I'm not aware of anyone using mitomycin C on the donor bed. This donor bed is really, really thin. So I would be concerned about the risk of toxicity to the endothelial cells with mitomycin C. But who knows? It's used in other areas, and depending on how thin your bed is and how long you're going to leave it there, how much percolation of that mitomycin C through the cornea you might expect to find, then those would be the things to think about.
It's very individualized. Yes. Yes. Do you ever request PKP tissue and then just remove endothelium when first learning this technique if you succeed with the grip and rip?
So I've thought about that and thought about recommending that. The issue there, I think, becomes that your tissue is really thick, and getting that tissue to dive so that your recipient limbal stem cells are going to grow over that cornea, you can start to get into a hump problem in that wound edge. So it's not out of the question if you can get a really deep dissection, but I think you're going to find that it's more comfortable and everything seems to fit better with a cap that's about 400 microns rather than the range of 5 or 550 microns.
Very good. Here's a question here. Have you tried a vision graft tissue in lieu of fresh tissue, given you don't need the endothelium?
I have not specifically used the vision graft tissue, but we have used tissue that is months old. So in some cases, we were saving these tissues from the DMEC grafts and then using those tissues for the anterior caps and ALK tissues later. And those grafts could be saved for a very, very long time. I have seen where we've sewn on ALK caps that are almost white like a sheet of paper with edema from just their age. And those corneas, you can watch them clear as you sew them on.
Very good. Here's another question. Do you ever run into adhesion and need a blade?
There have been cases where I've used a blade. In fact, when I started doing this, at least the way Dr. Goosey taught me, we used a blade just to pull the tissue and use the stretched stromal fibers and gently touch them with a blade all the way through across the cornea. What I realized with time, the more and more I did these, was that the blade just really wasn't necessary. It's just a matter of putting enough traction on the cornea, and the cornea is going to dissect on its own. So rarely ever would I use a blade, and I'm really trying to avoid that because that's where you get into issues with perforation.
You may have addressed this in a different question, but I'm going to ask it anyway. It says, when do you remove the sutures? You said
sutures, we're going to talk about that because we're not done with this patient, but we'll go through that, yes, in just a moment.
Okay, and we have two people asking that. So with that said, why don't we finish the presentation? We'll get to the rest of these questions, but we have a few more after.
Sounds great. So here, what we have up is that patient that you just saw done. This is the right and left eye. So on the right side, you can see uncorrected vision of 20/150 on day 7, 20/150. Post-op day 1 for the left eye that you just saw the surgery for. Post-op day 1, 20/450, and on day 7, 20/250. Next slide. You can see the little bit of haze and edema there. These are all the left eye. Post-op day 1 is on your left-hand side. You can see on the OCT, slim flug images on the top, OCT images on the bottom, and you can see on the bottom, the OCT image, those posterior wrinkles and the irregularity of the posterior stroma there. By a week out, you can already see where those wrinkles are smoothing out and the tissue is becoming more uniform, and the edema that's in the tissue is resolving and tissue is becoming more compact. Next slide. Here are the pre-op pentacam shown on your left for the left eye, and on the right, the post-op pentacam day 7. You can see the respective Schlimmflug images with the opacity on the left side in the apex of the cornea. And on the right, that opacity is gone, and we can see the significant flattening that we've gotten. We started off with K1 and K2 of 67.2 and 70.6, which you can see in the pre-op images on the left. And on the right, the post-op images K1 of 41.8 and 46, with a Kmax of 43. The graft thickness here on OCT is 407, host at 161, and a total of 568. Next slide. So post-op care. So here's where you really earn your salt in cornea, is all the stuff that happens after the transplant. So post-op day 1, usually expect variable vision anywhere between hand motion and 20/150 usually. Use your typical drop preference. Steroid, antibiotic, and NSAID is what I usually use. Leave the bandage contact lens in for a week. At a week, we usually expect the vision somewhere on the chart, 2400 to 2150. Take the bandage contact lens out as long as the epithelium is healed. If it's not, we'll leave it there for another week, see the patient back in a week. Once it's healed, we'll stop the antibiotic and the NSAID and continue the steroids. I usually use loteprednol 3 times a day, and we plan to do that for 5 months. At the 3-month period, at the 3-month post-op visit, we'll remove every other suture. So the 12 o'clock, 2 o'clock, 4 o'clock, and so forth. And then at 5 months, I'll usually remove all sutures. Now, if there's a reason the patient has particularly severe keratoconus in both eyes or other opacities for both eyes simultaneously, then and they need to get into a contact lens as fast as possible, we will sometimes leave the sutures in place, go ahead and place or send the patient over for placement of a scleral contact lens at the 3-month mark. I've done that as soon as 1 month afterwards is the earliest that I've done it, but most of the time I tell patients, you know, what kind of results you're going to get and how stable they're going to be. We want to give it at least 3 months, and then after that they can get into a scleral contact. If we're planning to remove the sutures 1 month after removing all the sutures, which is at 5 months, then we'll send them for, in the 6th month post-op, send them for a scleral contact lens fit. At that point, we'll also stop all drops, and I usually don't keep them on drops longer than 6 months, unless we get into some issue like severe staph hypersensitivity, where we're doing this procedure, or stromal rejection. Next slide. So complications, what can go wrong here? Of course, perforation. When we have perforation, where does it happen? It's going to tend to happen with the trephination, which is one of the reasons why we like to do a large graft. If we're doing ALK for keratoconus cornea, then as we go larger, we get a thicker cornea, and there's less chance that we're going to perforate. So again, trephination is one of the places where you want to be careful, and that's why we like to go a little bit larger in these cases anyway. If you do get a perforation, you can treat it in the same way that you would treat a big bubble perforation. Air injected into the anterior chamber. You might then have to switch over and use sharp dissection to get you through. Again, that's really, really rare. I think in the last 16 years of doing this, it's maybe happened to me 3 times. 2 I can remember specifically. I'm throwing a 3rd one in there. That basically makes my perforation rate over the last 10 years, if you take 227 to 230 corneas over the last 10 years, we're talking a perforation rate of about 1.3%. There can be things in the interface, foreign bodies in the interface, infection, blood. These can be swept out. Pseudo AC can form. Again, I have been lucky enough to not have this. As long as you're sewing tight, this is not an issue that I would expect you get into. We want to warn the patient to come in for any loose sutures or any other problems that would be consistent with stromal rejection. Although it's very rare, it can still happen. Slow or poor wound healing is probably the most common complication, if you want to call it a complication, a thing that you need to at least be paying attention to. Because we're doing these cases on people that have stromal disease, oftentimes in HSV. If it's a young patient with HSV, I'll preferentially do an ALK if I can, so that they can keep their endothelium. In those cases, because they're already numb, we would expect them to have slower healing. In some cases, we may want to consider amniotic membrane or synedrimen in those cases to encourage the healing of the epithelium. Next slide. Long-term results, grafts tend to last many years. Because of the clarity and the absence of complications, we can really get through these things with very little complications or problems and great long-term results. Next slide. This is a case of a keratoconus with an apical scar. You can see that above for the right eye. The ALK was done in 2018. Now in 2021, we went from a pachymetry of 340 to 418. The opacity score on the pentacam went from 78 to 37. You can see the relative images there. Next slide. Here's a case of a keratoconic patient. This is the right and left eye of the same patient. On the left eye, which is on the right side, the ALK was done in 2012. On the right eye, the ALK was done in 2015. You can see the OCT images and the slim fluid images, as well as the pentacam maps there to show the regularity of the astigmatism and the relative depths of the dissections on each of these cases. In both eyes, this patient with scleral contact lenses was 2020. Next slide. Advantages: short learning curve, extremely low perforation rate, great clarity, fast, common instrumentation, less rejection than PKP, longer survival graft than PKP, stronger than PKP, and CorneaGen helps to make you successful. I'd encourage you to jump in and start doing grip and rip ALKs. I think you'll find that it's a much more satisfying experience than what you're experiencing with the big bubble. Next slide. Just for fun, this is just a case I put in of a PKP inside of a PKP. This is a 8.5 millimeter PKP inside of a 13. A really complicated patient we had with peripheral corneal melting. So just threw that in just for the fun of it. And next slide. These are the guys that help us out. This is Hayes and Oscar that help us in the OR. We're always appreciative of their help. I have my contact information here as well. Thanks everybody for participating. If there are any other questions that you have, I'd be happy to answer those now.
All right, we do have more questions here, Dr. Vital. Thank you, by the way. Thank you for a great presentation. It was terrific. We have a question here that says, have you ever considered, and I hope I'm saying this right, diathermy?
Diathermy.
Diathermy.
Yes. So this is something that Dr. Goosey had started doing, was doing some diathermy in the periphery to stretch the cornea to avoid some of those wrinkles. I've tried it on a couple of cases. I think he's probably found more success with it than I have. I think it's a great idea. I wish there was a little bit better control with it, but I think it's something that could warrant extra or more exploration, because I think it's a great idea. But because you have that residual stroma left over, and you can shrink and stretch that stroma, you can use that to help control the curvature of that posterior lamella.
Very good. And somebody just commented, they said, I have been using Moxidex on the bed for this purpose. Is that something you agree with?
Again, no problems with it. The dexamethasone and Moxie, to help with inflammation and avoid problems with infection in the interface, no issues.
Okay. What is the pentacam opacity score?
So PIT scan gives uh, a number that is not, it doesn't have any units. It's just a relative opacity. So very little to no light, total reflectivity will register as 100. And you'll see that on the SlimFlow images if you look for that green bar, and you can actually on the machine itself shift back and forth, and it will show you the relative opacity. So when you get to a perfectly clear cornea, if I image my own cornea, is somewhere in the range of about 23 to 30. You would consider no opacity whatsoever. And a cornea that has significant scarring, apical scar, stromal scar from herpes or trauma, you're going to see that very quickly jump to 100. It's very sensitive. So you usually either see clear or completely opacified is what it looks like. Rarely will you see something in the middle, but 70s or something like that will be a very fine haze. In these cases, you can see they're often in the range of 25 to 35 in terms of what those opacity scores end up.
Okay. And then have you performed in pediatric patients?
I love to do this in pediatric patients. It's fantastic for your peds cases and your Downs cases, because those are the ones that are going to be rubbing their eyes and all of those kinds of problems. So I feel much safer in doing these in kids and Downs patients.
I'm going to leave it to two more questions here. And again, I'll ask you for a little help in the translation of this question. It says, why do you use NSAID, NSAID for corneal transplant?
So I use an NSAID. I have a feeling that we as cornea doctors are probably inducing more macular edema than we give ourselves credit for. We know that in routine cataract surgery, you can do the slickest, fastest cataract surgery on the planet, and we're still expecting to see some macular edema there, even if it's only on fluorescein. With a corneal transplant, we're doing something that I would portend is more inflammatory, but we never look at the macula because the vision is so bad. So I make the assumption that the macula is at least insulted when we do our surgeries, and that an NSAID would help with that.
Very good. And we're going to end with this question, and I like it because it adds a little perspective. And somebody wrote here, previously I heard you talk back in 2016 or so, and I thought that you had been doing a 0.25 millimeter oversize for the donor in order to flatten these keratoconic eyes. Did I misunderstand, or did you change that portion of it? So
Yes, I did change that portion. I now go a little bit larger because I found in some cases it was difficult to close the graft, and I was actually getting too much flattening. In this particular case that I showed you, we started off with Ks in the range of about 70, and by oversizing by 0.5, we ended up Ks at about 41 by 43. So you can get too flat with this procedure if you're so tight. So by going a little bit larger on that donor, we're not getting the extreme flattening that's maybe a little too much.
very good. And then I just want to address the audience. I just want to say that following tonight's session, we'll email you a link to access this recording of today's webinar and a survey soliciting your feedback. We ask that you take a few minutes to complete the survey, as your comments will help guide us in presenting the best possible educational webinar as we move forward. And I want to say thank you, Dr. Vital. You were terrific. And I do want to make I took a couple notes, but I want to say I loved what you said early in your presentation where you said on Cornea Day you get a present. I love that. I think it's so sweet. Anyway, well done. You did a spectacular job, and we can't thank you enough. So thank you. And I want to say thank you to tonight's audience for being with us tonight. So happy holidays, everybody. Merry Christmas, and I hope you enjoy this time of the year with friends and family. Thank you.
Take care, everybody.